Good evening all. Can you hear me?
Hello ma'am, കേൾക്കാം ma'am.
So, my name is Dr. Anju. I'll be taking the class for you on complications of CSOM. The complications of CSOM is a very vast topic, so I'll try to finish up with this point. Can you see the slide?
Yes, ma'am.
So, moving on to the complication of CSOM, you know what is chronic separative otitis media. So, that is the spread of infection beyond the confines of the mucosal spaces of the media gut. So it can be divided, the complications can be divided into extracranial and intracranial. Extracranial is again divided into intratemporal and extratemporal. So the intracranial complications include meningitis, sigmoid sinus thrombosis, brain abscess, extradural abscess, subdural abscess, and otitis hydrocephalus. Whereas the extracranial intratemporal complications include mastoiditis, petrositis, labyrinthitis, and facial paralysis. And the extracranial extratemporal complications are subperiosteal abscess, basal abscess, zygomatic abscess, and digastric or sicarius abscess. So this is a diagram that is showing almost all the complications. Here you can see this is labyrinthitis. This is involving the facial nerve causing facial paralysis, involving the lateral sinus or the sigmoid sinus producing sigmoid sinus thrombosis. This is involving the mastoid anthem producing mastoiditis, and then the abscess going into the brain producing extradural abscess, subdural abscess, and even brain abscess. And even the inflammation of the meninges produces meningitis. So the predisposing factor for these complications include one is attico-antral disease, that is the polysteatoma presence, highly virulent organisms, poor host immune response, presence of preformed pathways for the spread, and the extremes of age and poor socioeconomic status. So the routes of spread can be either by bone erosion or by separative retrograde thrombophlebitis or by the preformed pathways. So direct bone erosion occurs in case of in acute separative otitis media, it is by the hyperemic decalcification, whereas in chronic separative otitis media, it is because of polysteatoma or granulation tissue. So the separative retrograde thrombophlebitis, the pathway is thrombosis of veins of the Hydrocephalus canals within the bone that will spread to the dural veins. And from the dural veins, it will involve the dural venous sinuses. And from the dural venous sinuses, can cause thrombophlebitis of the dural sinuses or cortical vein thrombosis. So the preformed pathways that we know as a congenital dehiscence like dehiscence in the facial canal or over the jugular bulb, or it can be patent sutures like petrosquamous suture, or it could be temporal bone fractures like the fibrous scar that permits the infection post temporal bone fracture, or it could be a surgical defect that was caused by stapedectomy or a fenestration and exposure of the dura. So the perilymphatic fistula can also occur, that can be congenital or acquired. And normal anatomical openings like infection of the labyrinth and from the labyrinth to the meninges. Normal anatomical openings are oval and round windows, internal acoustic meatus, enlarged cochlear duct in case of Montanese anomaly, and endolymphatic duct and sac. So the features of impending complications are like if the patient is having persistent ear pain or the patient is having fever, if there is severe headache or if there is projectile vomiting or if there is any neck stiffness or the patient has got photophobia or the patient is irritable or having altered consciousness, we should be suspecting that the patient is having some kind of complication. So moving on to the detail of each complication, the intratemporal complications, as already said, they could be petrositis. It can cause facial palsy. It can involve the labyrinth producing labyrinthitis, and it can go into the mastoid antrum producing mastoiditis. Now, mastoiditis is when infection spreads from the mucosal lining of the mastoid cells to involve the bony walls of the mastoid cell system. So, from the mastoid antrum, once involved bony lining, that is when it causes the mastoiditis. It can be acute coalescent mastoiditis as well as mass mastoiditis. Now, acute coalescent mastoiditis happens when there is a production of pus under the tension inside the mastoid antrum. There is so much of pus, and that will undergo hyperemic decalcification and osteoclastic resorption. That is by the action of a lot of enzymes like osteoclast producing a lot of enzymes like acid phosphatases, collagenases, etc. And that will cause destruction and coalescence of the air cells within that mastoid antrum. So that will become a single pus-filled cavity and producing the empyema of mastoid. So this is the pathophysiology of the coalescent mastoiditis. So how will a patient present to you? Patient will be presenting with a earache. He will have fever and there will be ear discharge which is profuse and purulent. When you look at examine the child, there will be mastoid tenderness. There will be sagging of the posterior superior meatal wall, eardrum perforation, and also there will be swelling and redness and bulging over the mastoid. That is called as the ironed out mastoid. And there will be conductive hearing loss. So, if there is a persistence of otorrhea beyond 3 weeks in a case of acute otitis media, that indicates mastoiditis. So, the investigations we do are oral swab for cultural sensitivity, and also we can go for HRCT temporal bone, high resolution CT scan of temporal bone if there are impending complications. So, the oral swab for cultural sensitivity, most common organs that we suspect are Streptococcus pneumonia, Pseudomonas aeruginosa, Group A beta hemolytic streptococci, Coagulus negative Staphylococcus, and others less commonly Staphylococcus aureus, Proteus, and Bacteriology. So this is an HRCT temporal bone which is showing the mastoid antrum. Now, there are differential diagnoses for acute mastoiditis. One of the differential diagnoses is pharyngeal of external auditory canal. So, how do you differentiate between acute mastoiditis and the pharyngeal of external auditory canal? Is in an acute mastoiditis, the patient will have ear discharge and acute otitis media, whereas in pharyngeal, there will be no discharge. And the discharge will be mucoid and mucopurulent in case of acute mastoiditis, whereas in pharyngeal, it will be just pain and swelling on the external auditory canal. And there will be conductive hearing loss is always present with mastoiditis, whereas it's only on canal occlusion in case of a pharyngeal. And there will be tenderness on the mastoid region in case of acute mastoiditis, whereas in pharyngeal, the pain can be either anterior or inferior to pain. And acute mastoiditis is usually painless, only when it becomes very severe, when there is it will become painful. Otherwise, it is painless, whereas pharyngeal is always painful. And the displacement of auricle can be mastoiditis with inferior, anterior, or lateral because you got the swelling in the post-auricular region. So that will push the auricle towards the anterior part. Whereas in pharyngeal, the displacement is only in the anterior part. Moving on to retroauricular sulcus. Retroauricular sulcus is not obliterate in acute mastoiditis because it is a subperiosteal, whereas in pharyngeal, it will be obliterated. And tympanic membrane perforation will be present in acute mastoiditis, whereas it is absent or will be normal in case of pharyngeal. And then sagging of posterior superior deep canal wall will be present in acute mastoiditis, whereas in pharyngeal it is usually affecting the cartilaginous part, so that sagging will be seen only in the cartilaginous part. And lymph node endopathy may be present in mastoiditis, but it is usually absent in pharyngeal. And imaging is done in case of acute mastoiditis that will show the destruction of the mastoid air cells, whereas in pharyngeal they will be normal. So then moving on to the treatment of acute mastoiditis, you have to admit the patient when it is severe, hospitalization is required, IV antibiotics should be given, and if it is not subsiding with IV antibiotics, we have to go for cortical mastoidectomy. So the secondly affected coalescent mastoiditis are subperiosteal abscess. So the abscess from the mastoid region can drain into various other regions like subperiosteal region, and it can go through the digastric tip, form basalt abscess. It can form Cichlids abscess in the occipital region. It can form Lux abscess in the premeatal wall. It can form petrositis. It can form labyrinthitis, facial paralysis, and meningitis, brain abscess, and sigmoid sinus thrombosis. So this is a diagram showing the various pneumatization of Mastoritis in relation to the Mastoid abscess. You can see the zygomatic cells, because there will be zygomatic cells are over here. So when they get infected, that is where you get flux abscess. And this is the styloid process, and this is external meningitis. Then here you have the mastoid process. Can you see the cursor?
Yes, ma'am.
Okay. So this is the mastoid process, and through the digastric tip, that is the pus can drain through the digastric tip to form the digastric abscess or the Separative abscess. Sorry, basalt abscess, and the digastric cells can also get involved in Separative abscess. And then you have this is the squamous portion. So what is mastoiditis? That is actually the slow destruction of the mastoid abscess. There, the acute signs and symptoms of acute mastoiditis are absent. That is probably because of inadequate antibiotic therapy, like dose, frequency, or duration. Whenever that is inadequate, that can result in mass mastoiditis. The patient will not have any pain, will not have discharge, will not have the fever or mastoid. Those acute signs of mastoiditis will not be present in this patient, but there will be mastoid pus inside it. So that will be only found in case of an HRCP temporal bone. And you have to, when you do a mastoidectomy, you can see that there is extensive destruction of vessels with granulation tissue and dark gelatinous material which is filling the mastoid. Now moving on to the next complication, that is the petrositis. So the petrositis occurs when the spread of infection from the middle ear and the mastoid goes to the petrous part of the temporal bone. May be associated with acute coalescent mastoiditis, latent mastoiditis, or chronic middle ear infection. So you can see this is the petrous portion. So from the middle ear mastoid region, from the mastoid region, the infection can spread to the petrous part of the temporal bone. This is the petrous part. This is the squamous part of the temporal bone. This is the zygomatic process. This is the mandibular fossa, external auditory meatus. This is the styloid process, and this is the mastoid process. So this is again showing the petrosphenoidal fissure and the petrooccipital fissure and the sphenoesquamous suture lines. So it is a rare consequence of acute otitis media, the petrositis. Inflammation and suppuration extend into the pneumatized petrous apex. Normally, marrow-filled cells of petrous apex prevent the spread of infection. Approximately 30% of the petrous apex are pneumatized, and they often lose its barrier. So, like mastoid, petrous bone may be of three types. Like pneumatized, it can be diploid, it can be sclerotic. Pneumatization occurs only 30% of cases with cells extending from the middle ear or the mastoid to the petrous apex. So this is the HRCT diagram showing the petrous apex. This is the petrous apex pneumatization. This is the mastoid abscess system. This is the petrous apex. Again, this is the petrous apex region. This is the mastoid abscess system, and this is the petrous apex. So the infection then go from the mastoid can reach up to the petrous apex. Usually, two cell tracts are recognized. That is the posterior-superior tract, and there is antero-inferior tract. The posterior-superior tract starts in the mastoid and runs behind or above the bony labyrinth to the petrous apex. And some cells even pass through the arch of superior semicircular canal to reach the apex. And antero-inferior tract starts with the hypotension near the eustachian tube and then runs around the cochlear to reach the petrous apex. So one goes below, one goes above. So the infective process runs along these cell tracts and reaches the petrous apex. The pathological process is similar to that of coalescent mastoiditis, forming an epidural abscess at the petrous apex involving the cranial nerve 6 and the trigeminal ganglia. So acute inflammation in the mucous membrane of the petrous apex cells will progress to abscess and osteitis. There will be chronic cases. There can be inflammation, resorption, and newborn formation. Anatomical proximity of the petrous apex to meninges can affect cranial nerve 5 as well as the carotid artery. So again, the complications is the spread of abscess to meninges producing meningitis, brain abscess, extradural abscess, multiple cranial nerve palsy, and carotid artery thrombosis. So when pneumatized and marrow-containing space of petrous apex become infected, the potential routes of drainage can become obstructed and they lead to persistent infection. So the lower incidence of acute petrous apicitis as compared to mastoiditis is attributable to lower incidence of petrous apex pneumatization. And venous channels to pittus apex may provide additional pathways for dissemination of infection. There is Horner syndrome with involvement of sympathetic nerves around the pittus portion of internal carotid artery, and that will be associated with cochlear vestibular findings, facial weakness, and signs of systemic infection. Now, Gradningo syndrome is very important. That is a triad that consists of cranial of 6 palsy, reducing retroorbital, reducing lateral access palsy, deep-seated retroorbital pain, and there will be persistent otorrhea. So the persistent ear discharge in case of a cortical or modified radical mastectomy may be due to petrositis also. The retroorbital pain is irritation of the Gazarian ganglion, which contains the trigeminal nerve within the Meckel's cave on the anterior surface of pittus apex. Diplopia is secondary to the lateral rectus muscle palsy, that is the cranial nerve 6, as it passes through the Doralus canal, which is a fold in the pectoroclinoid ligament, and only a minority will present with all the full symptoms. There will be fever, headache, vomiting, and sometimes neck rigidity. Some patients may get facial paralysis and recurrent vertigo due to the involvement of facial and statocaustic nerves. So how do we diagnose it? We require both CT scan and MRI. CT scan of temporal bone will show bony details of pittus apex and aces, and MRI will help to differentiate between the diploid marrow containing apex from the fluid orifice. So CT will show a pittus opacification if it is present, if there is a coalescence or disruption of the local anatomy. And post-contrast, even MRI can also demonstrate if there is a granulation tissue in the pittus apex and around the carotid artery or involving the Meckel's cave. So moving on to management, we have to take an HRCT temporal bone, we have to give IV antibiotics, and we have to do for it surgical exploration. So the cortical modified radical or radical mastoidectomy is often required, if not already done. Fistulous tract has to be found out, and it is then curated and enlarged to provide a free drainage. In the tract of posterior superior cell tracts starts in the Trochlear's triangle or in the attic. So tract of anterior cells is situated near the tympanic opening of the eustachian tube, passes above the carotid artery, anterior to the cochlea. In the latter case, radical mastoidectomy is required. So you have to give suitable intravenous antibacterial therapy and then follow is a surgical intervention. Most cases of acute petrositis can now be cured with antibacterial therapy alone, and it should be given in high doses and continued for 4 to 5 days even after complete disappearance of symptoms. And treatment of pittus appendicitis is the expeditious removal of the source of infection. So meningotomy without tube placement can be done, but mastoidectomy and intravenous antibiotics are the recommended one. Corticosteroid use may be beneficial if cranial neuropathies are present. So drainage of pittus apex becomes necessary when there are several routes of infection has been defined. We can go for transnasal or transsphenoidal drainage if anatomy is favorable. Otherwise, transtympanic subcochlear drainage is the least invasive route via pittus ridge. These are the different surgical approaches to pittus apex. Here you can see it's between the carotid and cochlea. That is called as the Ramadia-Lempert approach, which is subcochlear. And then you have wisdom through the hypotympanic cells. This is another approach. And then above the horizontal behind the superior canal, subarcuate approach. And this is through the arch of superior semicircular canal, subfracturnus approach. And this is through the attic after tegment is removed. That is called the Thornwald's approach. Here you can see this is a vertical portion of the semina passing through. This is the oval window, round window. Moving on to the labyrinthitis. So the labyrinthitis is divided into 3 types. There is circumscribed labyrinthitis, diffuse serous labyrinthitis, as well as the diffuse separative labyrinthitis. So circumscribed labyrinthitis is actually the labyrinthine fistula. This is the labyrinthine fistula, where there is thinning or erosion of the bony capsule of the labyrinth, usually of the horizontal semicircular canal. So the etiological factors they include: one is chronic separative otitis media with cholesteatoma. That is the most common, and the neoplasms of the medulla like carcinoma or glomus tumor, and surgical or accidental trauma to the labyrinth. So on clinical features will be there is exposure of the membranous labyrinth, which will produce a vertigo, which will be induced by the pressure over the tragus. So different tests we can go for diagnosis include one is pressure of the tragus, is a fistula test. Fistula test can be done by either by applying pressure on the tragus, which induces pain, vertigo, nystagmus, and the nystagmus will be towards the ear under test. And Seagull speculum, that is also this is a Seagull speculum. That will help you to provide a positive pressure will be applied to the ear canal, and the nystagmus will be produced towards the affected ear. So with this speculum, you can apply the pressure. So this is how it's shown. So here applying pressure with the Seagull speculum, and that will provide the positive pressure. So that provide the positive pressure into the tympanic membrane, and you can see whether the patient is having vertigo, pain, or vomiting, nystagmus. So the treatment for labyrinthine fistula include, in case of mastoid exploration, is often required to eliminate the cause, and systemic antibiotic therapy can also be given. So what is diffuse serous labyrinthitis? It is diffuse intralabyrinthine inflammation without pus formation, and it is a reversible condition. So the etiological factors for serous labyrinthitis is a pre-existing circumscribed labyrinthitis or a previous labyrinthine fistula with a chronic medullary separation or polysteatoma, and in case of acute infections of medullary cleft, where the inflammation will spread through the annular ligament of the wrong window, and it can follow stapedectomy or fenestration operation. So there also you will have vertigo, nausea, and vomiting, and the nystagmus will be towards the affected side. So the treatment include bed rest, immobilization with affected ear above, antibacterial therapy, labyrinthine sedatives like prochlorobrazil, meningotomy can be done. Surgical is the treatment. It's a cortical mastoidectomy in case of acute mastoiditis and radical mastoidectomy in medullary polysteatoma. Now, third is the diffuse separative labyrinthitis. That is happens when there is diffuse pyogenic infection of the labyrinth with permanent loss of vestibular and the cochlear function. So the etiology is usually it follows serous labyrinthitis, pyogenic organisms entering into a pathological or a surgical fistula. So the clinical features will be acute vestibular failure. There will be severe nausea, vomiting, and vertigo. Nystagmus will be, Q-complaint will be towards the healthy side. There will be total loss of hearing, and there will be central compensation. So here the nystagmus is towards the healthy side because the affected side is having a dead labyrinth. That is why you have the nystagmus is towards the healthy side. So treatment is drainage of the source of infection by the operation by mastoidectomy. Moving on to the intracranial complications. So the intracranial first thing is the meningitis. So the inflammation of leptomeninges, that is a pyometric arachnoid matter, that is called as the meninges, pachymeninges, and leptomeninges. And the most common in this is intracranial complication, follows acute otitis media in children and infants, blood-borne spread, and in chronic separative otitis media is because of bone erosion or retrograde thrombophlebitis. So what are the clinical features you see in meningitis? Is rising temperature, which results in rigor, headache will be there, neck rigidity will be there. There will be photophobia and mental irritability, nausea and vomiting, drowsiness which may progress to delirium or coma, and can have cranial palsies and hemiplegia. So on examination, there will be neck rigidity. Kernig sign will be positive. So in Kernig sign, when you extend a flexed leg, there will be pain over the thigh. That is called as the Kernig sign. And Brudensky sign is when you flex the neck, there will be flexion of the legs. That is called as the Brudensky sign. And tendon reflexes will be exaggerated initially, but later they become sluggish or absent. So you have to take a proper history. Clinical presentation must be evaluated. And when you do investigation, you do a lumbar puncture, and the CSF will show increased cell count. There will be increased protein, there will be decreased sugar, and CT scan and MRI is also required. Treatment of meningitis is antimicrobials with steroids like dexamethasone can be given. Surgical is only in cases when the antimicrobials do not respond within 48 hours. Usually we give only antibiotics. Next is autogenic brain abscess. It develops in the temporal lobe or the cerebellum of the affected side. And temporal lobe abscess is twice as common as the cerebellar abscess. So in children, 25% of the brain abscess are autogenic, and in 50% case of the adults. So the brain abscess goes through 4 stages. The first stage is the stage of invasion, that is initial encephalitis, and is usually asymptomatic. There will be no much symptoms in that stage. Then you have is a stage of localization, that is the latent abscess formation. So there are also not much symptoms are present, where the nature is trying to localize the pus by formation of a capsule. Third is the stage of enlargement, that is the manifest abscess, when the zone of edema appears around the abscess and is responsible for aggravation of symptoms. Then that time there will be clinical features, like there will be raised intracranial tension and there will be disturbance of function in the cerebrum or cerebellum producing symptoms. And then stage of termination is the rupture of abscess producing fatal meningitis, and that can result in severe clinical features raising up with the raised intracranial tension. So this is a diagram showing the first is the stage of encephalitis, that is the stage of localization, and then formation of localization or formation of an abscess, and then edema occurs, and that is abscess surrounds by encephalitis, and then finally there is a rupture of abscess, and that spread of the abscess into the subarachnoid or into the ventricle. So the clinical features due to raised intracranial tension include headache, nausea, vomiting. There will be loss of consciousness, papillary edema will be there, and there will be slow pulse and subnormal temperature. So temporal lobe abscess is more common than cerebellar abscess. In temporal lobe abscess, there will be nominal aphasia, whereas in cerebellar abscess, there will be headache. Temporal lobe abscess features a homonymous hemianopia, contralateral motor paralysis, epileptic fits or Jacksonian seizures, pupillary changes in oculomotor palsy. Whereas cerebellar abscess will have spontaneous nystagmus, ipsilateral hypotonia and weakness, ipsilateral ataxia, pass pointing and intention tremor, and dysdiadochokinesia. So the investigations that we can do are skull X-ray and CT scan, X-ray mastoids or CT scan, and also we have to go for lumbar puncture. In case of autogenic brain abscess, then treatment include high-dose intravenous broad-spectrum antibiotics like ceftriaxone, metronidazole, and gentamicin. Dexamethasone can be given to reduce the cerebral edema. Anti-epileptics can be given, that is phenytoin, and antibiotic zeotropin oral toilet should be given. When the surgical is only required if it doesn't subside with all this, then you have to go with a multidisciplinary approach with the help of a neurosurgeon. Surgical drainage the abscess followed by mastoidectomy to clear the ear disorder. Moving on to the next complication, that is the lateral sinus thrombophlebitis. So lateral sinus thrombophlebitis, it is inflammation of the inner wall of the lateral venous sinus or the sigmoid sinus with the formation of an intrasinus thrombus. So here it is the 6% of all intracranial complications. In CSOM, there will be direct spread through the bone erosion and thrombophlebitis spread through the emissary veins. Whereas in acute separative otitis media, it is through the emissary veins. It is formed by the confluence, so the sigmoid sinus of the lateral venous sinus is formed by the confluence of the superior petrosal sinus and the transverse sinus and becomes internal jugular vein at its exit from the foramen jugular. So this is the venous drainage, as you can see. This is the superior sagittal sinus. This is the inferior sagittal sinus. Now this is where the sigmoid sinus is. Sorry. So the sigmoid sinus is formed from the superior petrosal sinus and the transverse sinus. This is the superior petrosal sinus. This is the transverse sinus. So these together forms the sigmoid sinus that will drain into the internal jugular vein. So here you can see this is from where the middle ear or cleft, where the infection is going into the lateral sinus. This is the lateral sinus where the thrombus formation occurs. And that is called as the lateral sinus thrombosis. So it can be directly through bone erosion due to granulation cholesteatoma, or it could be because of thrombophlebitis of the mastoid emissary veins, and that sign is called as the Grisinger's sign. So in Grisinger's sign, there will be erythema and edema and tenderness over the mastoid area. So these are different pathways of spread they are showing. This is erosion of bone by the granulation tissue. This is the emissary vein that can directly spread into the sinus. And also this is the preformed pathway in case of fracture line. If there is a fracture line, there's only fibrosis happens. So there is no complete closure happens. So that also forms a pathway. So when there is erosion of sigmoid sinus plate, the formation of perisinus abscess occurs. And then that causes inflammation of the outer wall. Later what happens is that from the outer wall, it spreads into the formation of endophlebitis. So there is outer wall inflammation. and then forms the endophlebitis, and that reaches the neural thrombus. There will be thrombus formation inside the sinus, and that also get infected. That will propagate, that will increase in size, will produce the occlusal unit, and that forms the intrasinus abscess. This is the intrasinus abscess, and then later this will get propagated. That is the rupture of this abscess, and that will spread to the other regions of the sinus. So, formation of perisinus abscess will penetrate the dura and reaches the intima, producing neural thrombus, which will form due to intimal damage, hypercoagulation. There will be decreased blood from the sinus, and then the bacteria will proliferate, and there will be in the thrombus. There will be platelet aggregation, there will be fibrin formation, there will be neural clot, and the necrosis of the clot will form an intramural abscess, and then later the clot propagates, and there will be occlusion of the vessel lumen, and the infected emboli will be given up in the circulation, producing metastatic abscess and later septicemia. So this is again showing the how the sigmoid sinus thromboses occurs. So here you can see the ossicles. So here you see the ossicles. Here you see the cholesteatoma that is spreading into the perisinus region of the sigmoid sinus. That is only outside the sigmoid sinus, and later it forms what? And later it spreads into formation of periphlebitis, and then it enters into this sinus forming the endophlebitis and the thrombus formation, and later it forms the lateral sinus abscess, lateral sinus thrombosis. So there will be different presentations. Usually this is again showing the superior petrosal sinus and the transverse sinus forming the sigmoid sinus. This is the superior petrosal sinus, this is the transverse sinus, together forming the sigmoid sinus, and there you can see the mastoid emissary vein also, and that brings into the internal jugular vein. So the thrombus formation is in the, and again the propagation is being served. That is, from this sigmoid sinus, it can go up also, like into the superior petrosal sinus, into the transverse sinus, and finally it can go into the cavernous sinus as well. This is again the propagation of thrombus, that is from the sigmoid sinus, it is going into the different venous sinuses, like superior petrosal as well as into the internal jugular vein. And finally, it can even go up to cavernous sinus. So the presentation is very high fever with periodic chills, that is the picket fence fever, due to periodic release of streptococci in the blood. So every time the streptococci is released from the septic thrombus, the patient will have a hike in fever, and then again the patient will come back to a somewhat normal decreased fever. So that is the picket fence fever type. There will be headache because of increased intracranial pressure, which is caused by interrupted cortical venous circulation, producing papilledema. Autoria can be there, which is refractory to antibiotic therapy, and there will be neck pain because of extension of thrombophlebitis if it goes in the jugular bulb. And into the internal jugular vein, the patient can have neck pain. So internal jugular vein will be, when you palpate internal jugular vein, it will be appear as a tender cord in the neck. Neck rigidity will be because of mental irritation. Torticollis may be seen due to cording of the neck muscles, nausea, vomiting, altered mental state and focal neurological signs, vertigo and nystagmus, and there will be seizure when there is temporal lobe involvement, and the patient will have lethargy. So one of the syndromes that is associated with this is the jugular foramen syndrome or the bonnet syndrome. There will be dysphonia and there will be hoarseness because of involvement of the 9th, 10th, and 11th cranial nerves. So when there is 10th cranial nerve involvement, the patient can have hoarseness. Soft palate dropping is because of 10th and 9th cranial nerve. There will be deviation of uvula towards the normal side because of 9th cranial nerve involvement. Dysphagia is because of 10th cranial nerve involvement. Loss of sensory functions from the posterior one again because of the glossopharyngeal nerve involvement. Decrease in the parotid gland secretion because of glossopharyngeal nerve. Loss of gag reflex is because of 10th nerve involvement. And sternocleidomastoid mastoid trapezius muscle paralysis because of the 11th nerve involvement. That is jugular foramen syndrome. So 9th, 10th, and 11th cranial nerve is involved, sometimes 12th also because of the clot in the jugular bulb. So there will be pain behind the ear due to irritation of auricular branches of 9th and 10th nerve, headache, hoarseness due to paralysis of laryngeal nerve, dysphagia, Horner syndrome can appear, and there will be wasting of affected side of the tongue. Deviation of uvula from the affected side to the opposite side, sensory loss in olfactics on the affected side, inability to adduct the vocal cords because of tendon palsy, weakness and wasting of sternocleidomastoid mastoid involvement of labyrinth. So the recovery depends on the collateral circulation, recanalization of the sinus. Surgical intervention is not required usually. Decompression and the removal of the clot is necessary. That is the structure that is piercing the skull in the base of the skull. Here you can see the olfactory bulb and the olfactory nerve. Here you can see the optic nerve and the ophthalmic artery through the optic canal. Then you can see the oculomotor nerve. And then this is middle meningeal artery. So you can see the fourth cranial nerve, that is the trochlear nerve, and the trigeminal. This is trigeminal. And then you can see this is the transverse sinus. And then you see hypoglossal nerve. This is the sigmoid sinus. And then here you see the glossopharyngeal 9th and 11th coming through the jugular foramen. And in front of that you can see is the hypoglossal canal, and 7 and 8 coming through the vestibular internal auditory meatus. So on clinical examination, the patient will have anemia, will be highly emaciated. Grisingers, and I already said there will be erythema, edema, and tenderness of the mastoid region. There will be Tobbe-IS test will be positive. Kronbeck test will be positive. Tobbe-IS test is when you apply pressure on the normal internal jugular vein, there will be rise in the CSF pressure. That is called as the Tobbe-IS test. Because the other side is already thrombosed. So when you obstruct the normal side, there will be causing a rise in CSF pressure. And Kronbeck test is when you apply pressure over the internal jugular vein, there will be engorgement of the retinal veins and supraorbital vein. And when you palpate the internal jugular vein, there is tenderness. Enlarged jugular nodes can be seen. Torticollis will be present, positive Koenig sign and Rudenski. So this is the Tobbe-IS. So you have is a thrombosed vein. Then you have is the, so when you compress over the normal side, you can see there is a CSF pressure increase. Whereas in thrombosed side, when you apply pressure, there will be no change because there is no pressure transmission. So bacteriology in acute case, it is hemolytic streptococci, pneumococci, and staphylococci. Whereas in chronic, it is the Bacillus proteus, Pseudomonas, E. coli, Bacteriology, Staphylococcus, anaerobic, and gram-negative. So when you examine CSF, there will be increased polymorphs in case of complete blood count. CSF examination will show increased intracranial pressure. You should go for culture and sensitivity of the ear swab and culture sensitivity of the pus material from the sinus if available. On imaging, when you do an CT head, you'll be seeing a delta sign. That is, the thrombus will appear as a delta sign will be seen. So the delta sign is showing the thrombus with a triangular area with rim enhancement and central low density, which is seen in the posterior cranial fossa. So there is a central triangular area, low density surrounded by rim enhancement. That is called as delta sign. Gadolinium enhanced MRI can be done when you see delta sign. MRI is investigation of choice in the combination with CT. Serial MR venography can also be done with MRI to see the fluid propagation and resonance. Treatment is a combination of medical and surgical. So first we go for medical IV antibiotics. Anticoagulants only if clot is in superior sagittal sinus or increased intracranial pressure persists despite medical management. Surgical management includes mastoidectomy and removal of clot from the sinus. In case of acute separative otitis media, you have to go for cortical mastoidectomy and removal of the sinus plate. And whereas in case of chronic separative otitis media with cholesteatoma, we go for radical mastoidectomy. That is, we remove the entire mastoid axis, as well as if there is sigmoid sinus thrombosis, we have to thin out the bone around the sigmoid sinus and we have to remove the thrombus. If it is refractory septicemia, then you have to go for internal jugular vein ligation to stop the emboli being thrown into the circulation as well. Post-operative antibiotics must be given for 2 to 3 weeks, and post-operative have to follow up the patient with MRI as well as MR venography. The complications are usually lateral, sometimes contralateral also. Due to hematological spread, the complications mainly because of the spread of the thrombus. Like they can be septicemia, they can be meningitis, subdural abscess, cerebellar abscess, and other thrombosis. So because of effective medical and surgical management, the mortality has decreased 5% to less than 10%. So these are just the sinuses that are showing, which are different sinuses in our brain: inferior sagittal sinus, superior sagittal sinus, straight sinus, occipital sinus, and more. Now, clinical features, we already said hepatic fever with rigors, headache, progressive anemia, immunization. To a single sign, there will be papilledema, tobias skin, and choroidic skin, as well as there will be tenderness along the jugular vein. This is the diagram showing hectic picket fence fever. So there will be, whenever the bacteria is released into the circulation, you will have a hiking fever followed by a depression. Again, there will be hiking fever, there will be depression. That is the picket fence fever. So, blood examination, X-ray, mastoid, imaging, culture and sensitivity must be done. Treatment is either antibiotics and mastoidectomy. So you have to expose the sinus. When you do a mastoidectomy, we have to expose the sinus and you have to confirm and feel the thrombus. Next is the epidural abscess. So epidural abscess occurs when there is a collection of pus between the bone and the duramen. That is outside the duramen. That is the epidural abscess. So the affected dura is covered with granulation and they appear unhealthy and discolored. In acute otitis media, the bone over the dura will be destroyed by hyperemic decalcification, whereas in chronic otitis media by the cholesterol. So epidural abscess, mostly they will be asymptomatic and they are discovered accidentally during surgery. However, the presence is suspected when the patient has got persistent headache. There is severe pain in the ear, and there is general malaise with low-grade fever. Pulsatile purulent ear discharge, disappearance of headache with free flow of pus from the ear. That is called spontaneous abscess drainage. These are the features that you should suspect. Think of that there's a case of epidural abscess. So contrast in her CT scan or MRI must be taken. The treatment is antimicrobial therapy. If it is not responding to antimicrobial therapy, we have to surgically explore it. We have to do a mastoidectomy as well as removal of the epidural abscess. Then you have is the subdural abscess. This is the collection of pus between the dura and the arachnoid matter, that is under the dura, between the dura and the arachnoid matter, that is called as the subdural abscess. There is an otitis media. There can be erosion of tegment, and that is the erosion of dura, or it can produce brain abscess, and the brain abscess ruptures, and that can go into subinfection, subdural space, or by thrombophlebitis. So all the three routes can in fact lead to a subdural space infection and finally subdural empire. So the clinical features will be because of meningeal irritation, the patient can have fever, headache, malaise, drowsiness, neck rigidity, chronic and positive. Because of thrombophlebitis, there will be aphasia, hemianopia, hemiplegia Jacksonic fits, and also because of these intracranial pressure, there will be papilledema, ptosis, dilated pupil, and terminal involvement. So diagnosis again you have to do for CT and MRI. Treatment is surgical emergency. It is managed by the neurosurgeon. You have to drain the abscess and high dose of IV antibiotics must be given. Once patient is stabilized neurologically, then you go for the ear disease should be managed. Surgery of the ear, anti-epileptic medication can be. Next is otitis hydrocephalus, or it is benign intracranial hypertension. There is increased intracranial pressure with the normal CSF. That is the CSF will be normal, but there will be increased intracranial pressure. There will be severe headache. This is because of the spread of sinus thrombus from the lateral sinus, from the sigmoid sinus into the superior petrosal sinus. So there will be diplopia due to paralysis of 6 cranial nerve, blurring of vision due to papilledema, optic atrophy, and then results from the lateral sinus thrombosis. So it is characterized by raised intracranial pressure with normal CSF findings. So it's seen in children and adolescents with acute or chronic medullary. So when there is a lateral sinus thrombosis, that will cause obstruction of the venous system. So if the thrombus extends into the superior sagittal sinus, it will also impede the function of the arachnoid villi, and that causes raised intracranial pressure. So again, the patient will have headache, drowsiness, nausea and vomiting, blurring of vision, diplopia due to involvement of the sixth cranial nerve, baffle edema, sixth cranial nerve palsy, and eventually optic atrophy. So this is because of the retrograde extension of the Thrombophlebitis from the sigmoid sinus to the superior sagittal sinus. Blockade of arachnoid villi can occur. CSF is decreased absorption or increased secretion can happen. And there will be raised CSF pressure. But then otherwise the CSF will be normal. So lumbar puncture will show elevated CSF pressure by the normal biochemistry. It is done with caution because there is suspected. You should be very careful about herniation. CT scan can be taken. Imaging MRI is the imaging modality of choice. It allows for superior evaluation of the venous sinus. So HRCT temporal bone must be taken. Lumbar puncture is elevated CSF pressure about 300 millimeters of water can be seen. Treatment is acetylcholamide taken to reduce the CSF, diuretics, corticosteroids to reduce edema, and hyperosmolar agent. Lumboperitoneal shunt can be done if it is very severe. So eradication of the ear disease and lowering of the elevated intracranial, which is the goal of management. Then the recommendation is decompression of the sigmoid sinus can be done, or you can go for CSF fluid drainage by shunts, optic sheath decompression to prevent optic atrophy. So medical management include mannitol, diuretics, corticosteroids, and acetylcholamide. Any questions?
No, ma'am.
So when should I, what about the attendance?
Ma'am, I've taken screenshot. I will send you the attendance. And rest of the students are there on YouTube. Like, we have live screening also.
Okay. Okay. So I hope you have understood the complications. Please read it again once more. It is very volatile.
Hello, ma'am.
Yes, yes. Please
Ma'am,
read it again.
I can't hear you clearly.
Okay. Did you hear the class with me? Hello?
Hello, ma'am.
That's it. Okay. Okay, then. Shall we call today? No questions, right? No more doubts. Can you hear me? Class is over. Then shall we call today then?
Okay, ma'am.
Okay. Thank you.
Thank you, ma'am.